Hi, everyone. I'm Sherelle McClure.
Hi, my name is Jackie.
Hello, my name is Adam Taylor.
And my name is Nayelia de la Riva.
And we are here to talk about non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, also known as NASH. Next slide, please. So this is just a brief overview of what we'll be talking about today. We're going to start with an introduction and work our way to pathophysiology, current treatment, current research, and then we'll conclude with just some key points from our discussion today. So before we talk about non-alcoholic fatty liver disease, I do think it's important to quickly review the functions of the liver. The liver filters blood from our heart and our intestines, and it takes nutrients from the blood and it actually sorts, converts, and stores those nutrients depending upon what our body needs. The liver also regulates energy balance, it aids in digestion, and it filters toxins from the blood. So if you take a look at this picture on the right, this is actually from our textbook. It shows that amino acids are used in the liver to synthesize blood proteins. Speaking of energy balance, the liver stores glycogen and then releases that glycogen as glucose when our body needs energy. Fatty acids are used to synthesize things like cholesterol and lipoproteins in the liver. And then the liver also filters toxins such as alcohol. Next slide, please. So what is non-alcoholic fatty liver disease? It's actually a range of diseases that affects about a quarter of the US population. People with this disease have steatosis, also known as fatty liver. And this is basically when excess fat accumulates inside of the liver cells called hepatocytes. And that excess fat causes things like inflammation, swelling, and scarring in the liver. As the name implies, this disease is found in individuals who drink little to no alcohol. So for females, that would be about 1 alcoholic drink per day or less, and for males, about 2 or less. To the right, you'll see a picture of a healthy liver, and below that, you'll see a close-up or a zoom in of a healthy liver. So you'll see the hepatocytes as well as some liver enzymes. Next to that, you'll see a fatty liver. This is a liver of somebody with non-alcoholic fatty liver disease. You'll notice that it's yellow, which represents fat. And then in the zoom in below, you'll see fat droplets surrounding and inside of some of those hepatocytes, which shouldn't be there. Next slide, please. So there's 2 main types of non-alcoholic fatty liver disease. One is non-alcoholic fatty liver. This is the most common type and is characterized by steatosis, or that excess fat accumulation inside of those cells we talked about. There's no significant damage or inflammation associated with this type. However, some people do progress into the next type, which is non-alcoholic steatohepatitis, also known as NASH. So this type is less common. It affects about 1.5 to 6.5% of the US population, and is characterized not only by steatosis, but also by significant liver inflammation. And over time, this inflammation can become chronic and contribute to things like liver ballooning, which is when our cells enlarge due to the excess fat inside of them, and they eventually die. When they die, because the liver is regenerative, the liver will produce new cells over those dead cells. And that creates something called fibrosis or liver scarring. And over time, that excessive scarring can cause something called cirrhosis, which is permanent liver damage. And at that point, because it's irreversible, you would need a liver transplant to survive. Now, to the left, you'll see a picture of the progression of this disease. So starting with a healthy liver, you would progress to fatty liver, and you'll notice the fat on the yellow on the liver indicated by the yellow. And then from there, NASH, you'll notice that both fatty liver and NASH are reversible. But then once you progress to liver cirrhosis, that is irreversible, hence the liver transplant that you'd need at that point. Next slide, please. So risk factors and symptoms. One major risk factor of this disease is being overweight or obese. About 75% of overweight Americans have it. Insulin resistance is another one. 2/3 of people with type 2 diabetes in America have this disease. High triglycerides and high cholesterol are also risk factors. Age is also a risk factor. the likelihood of you getting this disease increases as you age. And then genetics. There are higher rates of non-alcoholic fatty liver disease and NASH in Hispanic Americans, followed by white Americans, and lastly, Asian Americans. Typically, there are no symptoms seen with this disease. It's called the silent killer for that reason. When we do see symptoms, it's usually towards the end stage of the disease. So thinking about chronic NASH or liver cirrhosis. And when you do have symptoms, they'd be things like jaundice, nausea, fatigue, weight loss due to a decreased appetite, or potentially pain under the right rib cage. And this picture just highlights why the pain would be located there. It's because that's where the liver is situated in the body. Next slide, please. Okay, diagnosis. As I mentioned in the previous slide, many people don't have any symptoms from the disease. So the first indicator is often someone going in for a routine checkup, getting blood work, and their physician finds abnormal liver enzymes or abnormal liver function tests. Once that indicator is seen, it can be then confirmed by a liver biopsy. To the right, we have a picture of the procedure of a liver biopsy. A physician will take a needle and drive it through the wall of the abdomen into the liver, and they'll extract a small piece of liver tissue. And then they can examine that tissue for signs of disease like liver stiffness or ballooning, as I mentioned previously, inflammation, scarring, etc. So this is the most effective method, but imaging can also be used. It's a little less invasive. So things like abdominal ultrasound, CTs, or MRIs can also be used. Next slide.
So the pathogenesis of NAFLD kind of has three parts to it. The first one having hormones playing a role in this. NAFLD patients suffer from obesity, as mentioned before. This results from the overnutrition of both the high-fat foods and the sugars. This leads to the activation of the opioid and the dopamine receptors. These two hormones are responsible for the craving portions. And this then leads to the activation of certain macronutrients in the systematic reduction of the gut-derived hormones. It increases and circulating triglyceride levels. The adipose derived hormones being the leptin and idoponectin both have a role in this. The leptin elevates in NAFLD and the idoponectin decreases in NAFLD. This image here that we have to the right shows how the leptin increases in the adipose tissue. And then as mentioned, that later on obese patients have NASH, which is a more crucial to the NAFLD, and it goes from the cytosis to the NASH to then the cirrhosis, which is a more crucial part that later on develops if it worsens. Next slide, please. The second part is the nutrition and the insulin. So due to the many challenges that the human nutrition faces, there's no reason as to why the macronutrients such as the high saturated fat, the low fiber, and the carbohydrate-rich diets increase and risk the NAFLD. In patients, it's still unknown and there are still further studies needed. But this is a three-hit process known as cytosis, as mentioned before, and lipotoxicity, which is the accumulation of lipids in the non-adipose tissue, and then inflammation in the liver. This leads to organelle failure in the mitochondrial dysfunctional and endoplasmic reticulum stress. This causes oxidative stress due to the oxidative fatty acids. And this is all seen in this image that we have here to the right, how the insulin resistance increases and in the muscles, and then the mitochondrial dysfunction and so on. So the underlying factor that appears to be the best fit for the NAFLD is the insulin resistance. having a bit of technical difficulties. So the third part to this is the role of genetics that has to do with this, and that is the gene, which is PNPLA3. And this has a protein of both triglycerol lipoids and iglycerol translase activity. And the signal nucleotide SNP, also known as, is associated with NAFLD. It's a G ally. And whether or not this is involved in the gene PNPLA3 in NAFLD patients, it is unclear and inconsistency in studies from the role of genetics in the pathogenesis of NAFLD, and further studies are needed. In this image here, we have the insulin resistance of obesity patients in the endoplasmatic reticulum, and then lead to the lipid droplets that then the gene there appears, the gene PNPL3. And then from there, it goes on and develops what is the NAFLD and the role of genetics that has a role in this.
So with that being said, we're going to move on to treatment and nutrition. The first point that I have is consuming low calorie foods, avoiding excess calories, since obesity is one of the leading causes of NAFLD. Eating excessive calories contributes to weight gain, which contributes to eventually obesity or anything like that. The best thing to do is to aim to eat foods that are nutrient dense. Foods can include fruits, whole grains, eggs, peas, beans, and these are very beneficial. The American Heart Association has said that nutrient dense foods allow individuals to get all the beneficial nutrients without consuming all of the excess amount of calories. And moving forward to the right, this picture kind of explains what nutrient density is. Eating nutrient dense foods, as I mentioned before, is they are relatively low calorie. You can eat a full meal and be full and get all the nutrients you need without having all these excess calories. And what I mean by that is like foods that are calorie dense foods. For example, if I'm going to eat salmon, rice, and some vegetables, that might be 400, 500, 600 calories, something like that, as opposed to if I ate a big burger from McDonald's, large fry, and a Coke, that could be 1200 calories or 13 or something like that. It's not worth it. And I'm losing the nutrients that I could be gaining, and I'm just tapping on calories, which doesn't contribute to the possibility of obesity. Next slide, please. My next point is time restricted feeding. This is when someone consumes all of their calories or all of their meals during a period of time that's generally roughly from 6 to 10 hours, only during the active phase of the day. The active phase of the day is when there's light outside. This will be anywhere from 7 a.m., 8 a.m. to latest maybe 5 p.m. or 6 p.m. And then there was a study that had shown it was a crossover feeding trial that was highly controlled, that would observe the effects of time restricted feeding involving overweight people that would take part in this for 5 weeks. And they all consumed similar calories and they consumed all the foods at identical times. And the benefits of this had shown improvement of insulin resistance, improvement on blood sugar regulation, improvement on appetite regulation. They were getting used to eating for 6 hours, and then they would fast for the rest of the day, which would help really regulate their appetite, knowing that they were only able to eat at this time. And the biggest and most important one is it reduced each and every person's weight and fat mass. With that being said, the picture over here on your right-hand side, it shows the early time restricted feeding compared to normal. It has that 8 a.m. to 3 p.m., 2 p.m. eating with a much longer fast, getting all your calories and your correct nutrients and the benefits of that. Next slide, please. The next point is consuming antioxidants. Well, an antioxidant is a substance that protects your cells from free radicals, and free radicals are molecules with an uneven amount of electrons, and free radicals are known for reacting to other molecules and leading to eventual chronic diseases. In that picture on the top right corner, it shows that uneven free radical electron moving away, and the antioxidant replaces that electron, which increases oxidative stress. What are some of the antioxidants? The main ones would be vitamin C and E. For vitamin C, it's about 65 to 90 milligrams per day with an upper limit of upwards to 2,000 milligrams per day. Vitamin E is 15 milligrams per day with an upper limit of roughly 1,000 milligrams per day. And any foods that would include antioxidants would be broccoli, spinach, carrots, a lot of vegetables, and a lot of fruits. And then individuals should remember it's always going to be food first, but if you're not consuming enough food, or you're possibly reaching a higher limit of calories when you shouldn't be, it'd be the best to look into taking supplements of either vitamin C or vitamin E. And with that chart over to the bottom right, it's just a good sources of antioxidants, ranging from, like what I said, a lot of fruits and vegetables. You got pears, bananas, cranberries, apricots, anything like that. Next slide.
All right, so I'll be talking about our primary research article, which was the effects of Mediterranean diet and antioxidant formulation in non-alcoholic fatty liver disease. The objective of this clinical trial was to compare the effects of the Mediterranean diet with or without antioxidant supplementation in overweight patients with non-alcoholic fatty liver disease. This study included 50 Caucasian overweight patients. They were then divided into 3 separate groups. Group A included 20 patients, and they were prescribed the Mediterranean diet and were recommended to do daily physical activity. Group B also included 20 patients. They were also prescribed the Mediterranean diet plus a antioxidant supplementation, as well as daily physical activity. And group C was just the control group who had no intervention. The participants in the study were then observed for 6 months with monthly phone interviews to monitor their compliance with the diet. Prior to the study, anthropometric parameters were taken, such as body weight, height, waist, and hip circumference. They also had blood work done, which they looked for serum levels of total cholesterol, LDL, triglycerides, glucose, insulin levels, creatine, and so forth. This data was collected both prior and after the study was concluded. So the results of the study showed that Group A had a significant decrease in weight, BMI, waist, and hip circumference, and an improve in the gamma GT, as well as total cholesterol, LDL. Group B also had similar improvements, but Group B showed not only a significant improvement in insulin sensitivity, but also a more consistent reduction of anthropometric parameters when compared to Group A. And Group C obviously had no significant decrease in any of the stuff due to them not having any intervention at all. And the table over here just concludes the results of the study, as you can see. So in conclusion, The study demonstrated that the Mediterranean diet may improve anthropometric parameters as well as lipid profile, and it may help reduce hepatic fat accumulation as well as liver stiffness. Moving forward, the Mediterranean diet with the antioxidant supplementation may help improve insulin sensitivity as well as improve anthropometric parameters and lipid profile as well. So overall, the study showed that there's a possibility of using antioxidant supplementation as a coadjuvant therapy for patients who are suffering from non-alcoholic fatty liver disease. Some limitations that I noticed from this study was that it only included a small population of 50 people. It would have been interesting to see this study in a more, just with more people in it. So more of the population could relate to it. They also only included people with a Caucasian background. I would have liked to see like more diversity. So again, more people could relate to the study and not just the Caucasian population. Lastly, the study only focused on obese or overweight individuals, which I would have liked to see the study done on like other people who are not obese or overweight, just because non-alcoholic fatty liver disease is not only seen in obese or overweight people, but it is also seen in people who have a healthy lifestyle.
And with that being said, this is our conclusion. NAFLD is a range of liver disease that affects a quarter of the US population with two given types. There is NAFL and NASH. NAFLD can be considered a silent killer. Most people tends to be diagnosed during a routine checkup, or if someone might be going into the doctor's office or the hospital for nausea, or they might have pain in their their rib cage or something like that. And then they would start to maybe feel like nauseous or anything like that of these symptoms. Why it could be a silent killer is when they usually be diagnosed. We also talked about NAFLD pathogenicity. It involves hormones, nutrition and insulin, and genetics, with the underlining factor that it is insulin resistant. Moving forward through that, nutrition therapy, which includes consuming low-calorie foods, time-restricting eating, and consuming antioxidants. Each of these could contribute to possibly lessening the symptoms or the disease, strengthening the liver. And finally, there was a study effective Mediterranean diet and antioxidant formulation in non-alcoholic fatty liver disease. This was a randomized study that involved 50 overweight individuals. As they went through the Mediterranean diet and antioxidant formulation, they were able to include that using an antioxidant supplementation could be coadjuvant therapy for patients with non-fatty liver disease. And then for our next slide, we have our resources of where we got all the information that built this PowerPoint slide. And with that being said, thank you so much for taking your time to listen, and I hope you have a wonderful rest of your day.